Good afternoon, everyone. It's my pleasure to introduce Dr. Paulo Boffetta. He is a professor in the Department of Family and Preventative Medicine at Stony Brook University with a distinguished and impressive background in international research. Graduated from the University of Turin with his medical doctorate, graduated from Columbia University with an MPH, a Master's of Public Health, and has done extensive research on the epidemiology and prevention of cancer. He is clinically trained in preventative medicine. Many of his projects have involved World Trade Center survivors and responders, and that's what we are excited to hear about today. It's my pleasure to introduce him, and I look forward to learning more about this topic. Thank you.
Okay, thank you very much, Brian, for the nice introduction. And I'm very, very glad to the program, to Tanya, Travis, and their collaborators for giving me this opportunity to present the results of this project, which is now getting to its end. This is part of a collaborative work done by a very large number of people. I will mention them at the end, but I want to mention in particular Dr. Charlie Hall, whom Anne has already mentioned, because he is my co-PI for this project. And as Anne said, he is ready to step in and give a much better presentation than mine, I think, in case I have some technical issues, but I hope that everything will go fine. So if I can have the next slide, we listed here the many funding resources we had which supported this project, but also in general the parent cohorts and the other projects that were being done as part of this multi-center collaboration. So you see there are many cooperative agreements with NIOSH, but also a number of other agencies that stepped in and supported this effort, including in particular NIH and a number of local agencies, New York State and New York City Department of Health, etc. So we can go maybe to the next slide. I have I've not included a very large introduction on the 9/11 terrorist attack, because I imagine this is known to most of the audience. However, I included a few slides. By the way, several of these slides were prepared by Charlie Hall, were modified by presentation that we had together over the years. So I just had a few slides pointing out some of the key aspects of exposure that would be relevant for the type of study that I would present this afternoon. So there are many thousands of workers who were exposed in different circumstances following the attack, both at the site and in other settings. Let's see, can I have a pointer, or this is probably not feasible? Let's see. Okay, so the work went on until well, officially until June 2002, and as you see, there were a number of other type of work that were considered exposed. Can we go to the next slide, please? So there has been some analysis of dust done at the time of the attack. This was done in particular in Paul Lyoi's group at Rutgers, and there were many agents that would basically would mainly be categorized in three groups. On the one hand, known as suspected carcinogens, then lung agent that may result in acute respiratory effects, and then also biohazards. Obviously, the exposure was very complex and depends on the time and on the location. However, there are many important aspects of the exposure circumstances that are still not fully understood. So our ability to connect any specific result to specific agents is somehow limited. Also because, at least for chronic disease, the latency that has elapsed since the attack may still not be sufficiently long. Can we go to the next slide, please, Anne? So, and this was just one of the key papers that were published shortly after 9/11 was published in 2002, where there were some of these early characterization of the type of exposure, with Paul as a main author. Okay, next. So, what drove us a few years back to propose this analysis of mortality in the population of World Trade Center rescue recovery workers? On the one hand, I think it is something that is due to these people, to let them understand how their mortality experience there in a collective sense is unfolding as time passes from the attack. But then there were a number of relatively important, or to our opinion, quite important questions from a scientific point of view. So on the one hand, there is the characteristics of the exposure, which was very high level, at least for some of the workers, with the gradient, obviously, but for many of them, relatively short term, and with the potentially, however, long-term effects. And then there has been the establishment of a number of medical programs targeted to this population, in particular with respect to screening and respect to access to diagnostic and treatment modalities, which would be important also to assess, which again, whose assessment would go just beyond, this population may have a broader importance. So let's go to the next slide. I hope, can you hear me well? I think it's going okay. My connection. I hope so. I give it for granted. Okay, good.
Thank you, Doctor.
So, as I said at the beginning, as also Travis and Brian said, this is a collaborative effort, which is based on 3 cohorts of workers who were independently started. And by the way, early results or other results on cancer incidence on the same pooled population, the same collaborative study, have been presented by Charlie Hall in the very first seminar of this series, early in 2022, about 1.5 years ago. So I'm just continuing the sort of the presentation of the results from the same collaborative effort. So the 3 cohorts are listed here. They were called, the first one was the fire department, first alphabetically, I just say, was the cohort of the fire department of the city of New York, based on 5 health clinics. Obviously, it included mainly firefighters and a few EMS workers. This includes workers who were active in 2001 at the time of the accident, and then added retirees as volunteers later. The second is what is now called the general responder cohorts, which is based on 5 clinical center of excellence with a total of 8 clinics around the New York metropolitan area. The data coordinating center is at Mount Sinai School of Medicine, and these are the main occupational groups. This is a volunteer cohort and is still an open cohort in terms of enrollment, although, as you can imagine, enrollment went down with time. So police officers, construction workers, communication workers are the 3 main groups. And then the third is called the World Trade Center Health Registry. This is maintained at the Department of Health of New York City. And this includes, again, a variety of workers and does not include a medical monitoring and treatment program. There is also a large cohort of people who were exposed to the accident, not as rescue recovery workers, but as community resident and other type of workers who were working in the area. And this is not included in our analysis. And this is a closed cohort. People were enrolled between 2003 and 2004. Okay, next slide, please. So as I said, these are not the residents and the workers other than those involved in the recovery, the rescue recovery, were not included. But and then obviously the other programs, national programs, and the program for Pentagon and Shanksville responders are not included in this collaboration. Okay, next, please. There has been a number of papers published over the years. I just listed here the 3 most recent analyses for the individual cohorts. And you have already a glance that for each of them, well, they obviously have slightly different follow-up time, etc., because they were conducted, these analyses were conducted independently and with, with slightly different methodology. But the interesting point is that all 3 cohorts seem to have an overall mortality ratio compared to the state or the US reference population, which is below unity. So the mortality in the 3 cohorts appear to be lower than what would be expected based on the national or the state rates. There's been more papers, but I'm just listing here the last of each of the most recent paper for each of the 3 cohorts. I hope I didn't make any mistake, but that's as far as I keep following, the literature. Okay, next slide, please. So this is the paper that we published a few years back now in 2021, 2 years back, describing this effort to combine the 3 cohorts into one pooled analysis. It seems straightforward, and myself, I've been working on pooled data set, pooling cohort and case control study over the years, but this has been quite challenging for the reason I already mentioned briefly, that these 3 cohorts were established independently with a slightly different methodology, inclusion criteria, and so on. So there was a very intensive effort from the groups coming from the different institutions involved. So the fire department and Albert Einstein, which is connected to it, Mount Sinai, where I was working at the time when we established the collaboration, and the Department of Health, as well as the New York State Cancer Registry, which played a key role in this, in our ability to put all these pieces together. So this is a paper which describes this effort to combine the 3 cohorts, and I will show one more slide based on this paper, which if we go to the next one, well, 2 more slides then. This is a slide prepared by Charlie Hall showing the very complex pathway that we had to go in order to get approvals by the institutions involved, by the cancer registries of the different states where we did the follow-up for cancer incidents, etc. It was an extremely complex effort, which was led really by Charlie and his collaborators at fire department and Einstein, together with the participation, obviously, of all the different partners. And as you see, just here for those of you involved in IRB applications, oh, it's J.W. Lee and Robert Breckville to prepare the diagram. Okay, but Charlie, you did most of the work anyway, or you coordinated most of the work. So for those of you who are used to go through IRB applications, just imagine that we have to deal with 17 different IRBs to put together all this very extensive data set. Okay, so can we go to the next slide? So this is just an overview of the pooled data set. So you see the 3 original cohorts. with the numbers of recovery workers who were available at the time when pooling was conducted. And as expected, there was some overlap, which was one of the important aspects to address. And by the way, these overlaps were one of the reasons why we felt it was important to go for a pooled analysis compared to just looking at the individual papers of each of the cohorts. Because when you look at the results of each cohort, like the slide I showed a minute ago with a very short summary, you don't know to which extent these are independent studies or are overlapping, etc. So what we aim to do here was really to have one single cohort which could be analyzed as much as possible in a harmonized, homogeneous way. So at the end, I think if you click again, there should be some more information. No, sorry. Sorry, can you stay on the previous slide? Sorry. So at the end, we had about 60,000 workers, and you have here the numbers, which gives some idea of the overlap. Not unexpectedly, the largest overlap was between the two volunteer cohorts, because people could go just to both to enroll in both. And you have also an idea of the relative contribution of each of the three cohorts to the pooled data set. Okay, so next slide gives some key information. So the most of the people were aged 30 to 50 to 49 at the time of the attack. And now more than 20 years have passed, so we have an idea of what is the age distribution of the members of the cohort now. It is largely a non-Hispanic white cohort, although we have, as you see, a sizable number of Hispanic and Black workers. And in fact, we just published an analysis of cancer incidence by race ethnicity, going into detail of what, whether there are any differences between the three major groups, which may or may not be explained by the pattern that are seen in the US population at large. It's largely a male cohort. We have 15% women in the overall cohort. And one important characteristic, and I will come back to this a bit later, is that the proportion of never smokers is pretty high. Although some of the cohorts, in particular the general responder cohort, is still open, the majority of the workers were enrolled, let's say, between 2002 and 2004. Okay, can we go to the next slide, please? As I said, the harmonization work was extensive, not only in terms of getting together the cohort with the social demographic information, but also to try to get some harmonization of the exposure data which were available. So we had basically a date of arrival at the site as the main one of the main exposure variables, and about 1/3 of the total population was at the site on the day of the attack, and another 18% on the subsequent day. And about 80% in total, 82%, were exposed within the first week, the first 6 days, and 18% only later. 93% were at the site, and 77% were in the other locations, in particular in the Fresh Kills landfill in Staten Island and in other locations. And then we had some categories of dust exposure, with about 50%, half of the people in the lowest category, and then you see here the distribution. And finally, we have a variable which, which was indicating whether the people were working directly on the pile, on the debris pile, and this was positive for slightly more than 1/3 of the workers. And I will come back to some of these variables as we present the results. Okay, the next slide. So this is the main paper, which was published earlier this year from this effort, looking at the mortality this pooled cohort. As I said, Charlie presented earlier last year a number of analyses done on cancer incidence. Jay Hui Lee from the Department of Health, as you see, was the main author of this, is the main author of this paper. And by the way, I see that many of our collaborators are present in the audience today, including her, so I'm very glad and very grateful that they are also present. Okay, next slide. So the mortality analysis, 631 workers, we did a common linkage to the Hello? Yeah. We did a common linkage for mortality with the National Death Index up to 2016. So there is some room now for updating. The average duration of follow-up was 11.5 years, with a total about 700,000 person years. And at that point, 3.2% of the cohort was dead. So 1,912 dead. We did two sets of analysis, one based on indirect standardization, and the other one was based on Cox regression. Next slide, please. So the standardized mortality ratio are probably known to many of you. I will just describe them very briefly for those with a more limited understanding of epidemiology. So we basically divide the cohort into different strata defined by age, typically 5-year age groups, race, ethnicity, and gender. And for each stratum, indicated by I in the formula, we compare we sum up all the observed deaths, so basically the total number of observed deaths in the cohort, which are divided by the number of expected deaths, which are calculated by summing up for each stratum the number of person years from the cohort multiplied by the rate in the reference population, okay, which are the parameters indicated here in red. So the reference population was we basically used New York State, although we did also analysis using the US population. And then we used statistical methodology to calculate the so-called exact confidence intervals. Okay, next. These are commonly used. Well, probably we don't need to go into much details here, but it's a relatively efficient way to study mortality. In particular, when a cohort is relatively large, and therefore each strata of the cohort include a reasonably large number of deaths, or not too many strata include very small number of deaths. Say. There are some other statistical aspect that we don't need to spend much time in this context. So we go to the next slide. However, as I said, when the number of cases is small, the number of deaths is small, we can get some imprecision in the results, and also we basically say that the reference population has no variability, which is probably true if the population is very large. What is more important is that each standardized mortality ratio depends on the rates in the reference population and the distribution of person years. So in a way, they are not comparable for different cohorts or different periods, unless we assume that this categorization across the different strata remain the same, which is usually not so true. So basically, it's something to keep in mind when we compare SMRs. For example, the three SMRs of the three cohorts that I showed in the slide earlier on suffer from this issue in terms of comparison. So it's always important to keep this in mind. And then obviously very important to select the proper reference population. Okay, next slide. Okay, so these are the main results of the results, say, of the major causes of death, the major categories of causes of death, using both the US and the New York State reference. And we have here the number of deaths in the cohort with a total of 1,912, as I said before. the SMR, and then the confidence interval. And as you probably most of you know, if the confidence interval does not include the value of 1, which means the two the observed and the expected are the same. If the confidence interval excludes 1, it is said to be statistically significant at the level of significance of the confidence interval, and we use 95%. So as you can easily see here, all the mortality ratios for all these major causes were statistically significantly lower than 1. So the mortality in the World Trade Center population was lower than what is expected, and this was true both using the US and the New York State reference. And you can notice that the SMR using the US population are slightly lower, which means that the mortality in the US is is slightly lower than the one in New York State, so the ratio becomes lower. But anyway, there is for several causes the two numbers are very close, so it doesn't make a big difference. So we have a reduction of about 50% of overall mortality, about 35-40% for cancer mortality, and the results, the mortality is particularly low for respiratory disease and digestive disease, and to some extent also heart disease. And even for causes of death like violence, this cohort has a favorable mortality compared to these references. Okay, the next slide goes a little bit more in detail. Obviously, I don't have time to go into each aspect of the results. These are more specific causes of death. The first one is basically lung cancer. Respiratory system is the vast majority is lung, and we have a very substantial decrease in mortality of the order of 50% or more. Diabetes, the reduction is extremely large, and for many other diseases, even including suicide, at least with a comparison with the US population. And homicide is also very low. Okay, so let's go to the next slide. I'm comparing here for some cancers. Again, I have to do some selection to go relatively fast. The results on mortality, the one I just showed here, with the results that Charlie presented last year on cancer incidence, to understand to which extent the reduction in mortality is simply how can I say, a reflection, a consequence of the decrease in incidence, or to which extent it has a larger or a less pronounced effect. And we can see that basically for all these three cancers that I selected, we have a reduction in mortality which is larger than the one observed for cancer incidence. All three had also decrease in cancer incidence, but you can see the decrease for mortality is more pronounced. And this is particularly true for oral and pharyngeal cancer. You see that there was about a 10% decrease, not statistically significant when we look at the number of cases of cancer, and then the mortality was less than half of the expected. Much less so for lung, the two numbers are similar, and also for breast cancer, quite surprisingly, the numbers are not so different. But anyway, there seems to be a decreased risk of cancer in this population, at least for several, and Charlie discussed in his presentation the cancer for which we found an increase, including prostate, thyroid, oropharyngeal, tonsil, melanoma, etc. But for those for many others, there was a decreased incidence, but then there is a favorable effect on mortality also. Okay, next slide, please. Okay, here we go into a little bit more detailed results. Here we have results of the internal analysis based on on Cox regression. So results are reported as hazard ratio, HR, in which we have one category of gender, race, ethnicity, smoking status as a reference, and the result is the relative risk for the other categories compared to the reference. Okay, so we are no longer comparing rescue recovery workers to the external population, but we are working only within the cohort. And we see that, and I presented just 4 causes of death overall: heart disease, all cancer, and we put all the smoking related diseases, cancer and non-cancer, together, just for sake of, just to look at some particular aspect. And we see that men have consistently higher mortality than women. Everything has been adjusted for. So we adjusted for age, we adjusted for calendar period, for cohort membership, etc. Non-Hispanic Black have high mortality, not for cancer, but for the other causes compared to white, while the non-Hispanic others, so Asians basically, and Hispanic, have a mortality which is not statistically different from that of the white workers. Although the number, as you remember from one of the earlier slides, is not very large, especially for the Asians. For the Hispanic is sort of okay, but we see no statistically significant difference, which in fact appears to be present for Black workers. As expected, smokers have a higher mortality than non-smokers. We have here the reference category are the never smokers. We have a group of former smokers, not very large because this is a relatively young population, and then current smokers have about 2.5-fold higher mortality compared to never smokers. And as expected, these are in particular heart disease, and this last category are particularly related to smoking. We have a higher hazard ratio. Okay, next slide. And these are some of the data based on the exposure variables. In particular, these are results by date of first arrival. And we have here the group of workers who arrived at the site after the first week as the reference category. And then we have those who arrived the first day, the second day, and the rest of the first week by cohort membership, because we noticed that there were some differences in this effect by cohort. And in fact, as you see, well, we can look at the overall mortality, the first column here. We see that for fire department workers, firefighters from the fire department, there was a decreased mortality, in particular for those who were there on the first day and obviously survived at many, as we know, many firefighters were killed acutely. I mean, they were killed during the collapse of the towers, etc. So, but for those who obviously survived, were not killed on the day, they had a much lower mortality compared to those who arrived later. Instead, for the other cohorts, and in particular for the cohort of the Department of Health, here we call it non-FDNY, non-general responder cohort, there was the opposite effect. Those who arrived earlier had a higher, those who were present in the first day had a higher mortality in the subsequent years compared to those who arrived later. And this is particularly true in the first day, but is somehow present also in the subsequent days. And is present for heart disease and for smoking-related disease, again, less so for cancer, where the results are not really statistically different for any of these categories. So we see this so-called interaction or modification of the effect of the arrival day according to which cohort people are. Okay, next slide. This is working on the pile, and we have a very similar type of, because obviously the two variables are highly correlated. So a reduction for FDNY members compared to those not working on the pile, and increasing those from who were in the DOH cohort. Okay, next. So These are the results of the main overall analysis, which, as I said, was published last year. So reduction for most causes of death. It was the reduction is stronger for cancer, for most cancers, compared to the results for incidence of cancer. There was an effect of water center exposure for GRC to some extent, and definitely for the DOH cohort, but not for the fire department cohort. And we are doing some additional, we plan to do some additional analysis by time of follow-up to see how much these results have changed. Obviously, we've been thinking about how what can be the reasons of this reduced mortality, and we consider two factors that I will briefly address now. One is the so-called healthy worker effect, and then with something which is somehow related, which is confounding by major risk factors. So the next slide addresses the healthy worker effect. Sorry, no, I put the slide smoking. This is the prevalence. No, please go to the next slide. Okay, so these are the results on prevalence of current smokers in 2001. So at the time of the accident, this is the prevalence in our cohort for current smokers. And these are the data for New York State and New York City in 2001. And we can see that overall, and for each social demographic category, the Water Center cohort has a lower prevalence of smokers compared to New York State, in particular because the comparison for the SMR were done with the New York State population. Overall, there is about almost 8% reduction, which is about 1/3 of the total, 2015 instead of 23. And this is particularly pronounced for older people, but also for the younger people. And this is true, is less true for African Americans, but is present in basically all the groups. So what I did in the next slide was to try to calculate the effect of this difference in current smokers on lung cancer, just to give one example. So I had to make a number of assumptions. What is the rate of lung cancer in never smokers? What is the relative risk of lung cancer for current smokers? And I use some pooled analysis, meta-analysis, etc. I tried to use different rates and relative risk for men and women. So I also compare the proportion of women in the two populations, New York State and World Trade Center, and that is treated to the 40 to 84 year. So what I got was a rate ratio of 0.9, which means that this difference of smoking rate that I showed in the previous slide would explain only a 10% decrease in mortality from lung cancer in the World Trade Center because of the lower smoking ratio. However, it's a very crude adjustment, and I think this would be an interesting aspect to develop, not only for lung cancer, obviously, but for mortality in general in this cohort. We used only recent prevalence data, but in fact, it would be interesting to try to go farther back because lung cancer is due to a cumulative effect over several decades. Well, I did include former smokers. There are not too many, but still they will have an effect. And we didn't adjust for age within this age group. So the population of New York is probably older than the one at the World Trade Center, even in that age range. And has not been taken account. But this is just an example of what can be done to try to understand the possible role of some of these important determinant of health. Obesity obviously would be another one, and so on. Okay, so the next slide. So the other aspect that we have been addressing is the healthy worker effect, which has several components. Well, there is no time to go into the detail, that many of the people in the audience are probably very familiar, and they've been working on the healthy worker effect themselves. we really tried to address the healthy higher effect by basically selection into the cohort of a more healthy population compared to the general population. And there are several ways to address this, which is to adjust for employment status, and we did it also to do some more sophisticated modeling, like running G estimation models, which takes into account mainly the survival effect, which I don't think in this particular case is the most important component. And also the use of comparable cohorts, people who were also employed in the same occupations, but were not exposed to the World Trade Center. So keep in mind, healthy higher effect basically means that in the working populations, a number of people with a higher risk of dying, people with chronic illnesses, etc., are less likely to be included compared to the general population they are exposed to. And this is particularly true when we have a young cohort, which is very much the case here. If you remember, many of the people were in their 30s and 40s at the beginning of follow-up. So now they are in their late 50s or 50s and 60s or whatever, but most of the follow-up period has been done during relatively young age. If you remember, only 3% of the cohort died. So it's really a young cohort yet. And this is why the healthy higher effect is probably likely to play a very important role here. So what we did was to go in looking for comparable cohorts. And so far we have found two approaches, and this is what I would describe now. The first one, if you can go to the next slide. The first one was about firefighters. And as many of you know, there is a large NIOSH sort of run cohort of urban firefighters from three large cities in the US, Philadelphia, Chicago, and San Francisco, which are part of several studies, etc. So we felt that this had similar how can I say, forces of selection into the court, similar to what had the New York firefighters. By the way, firefighters in the pool court don't include only New York FDNY, but most of them are from New York City. So they have, as you see here, similar physical performance, training, etc. And this is a work which has been done, as you can expect, by our friends at the fire department, Marlies Weber and Rachel Zay Owens, etc. And I would just show the results of a paper that was published earlier this year with Rachel as a first author. Can we go to the next slide? Yeah, this is the paper. Well, Ancura, in fact, was the first author. I'm sorry, Rachel was supporting author. By the way, Ancura is the person who gave me also the results for the smoking analysis that I described earlier today. So she's been really extremely helpful in all this process of going through the mortality analysis together with the people from DOH, Joey, etc. Okay, so let's see the results of this comparison of the World Trade Center exposed and the non-World Trade Center exposed firefighters. So overall, there were 10,800 in the FDNY cohort, 8,800 in the three other cohorts, people who were employed at the same time. The follow-up was done up to 2016 also, basically the same data for the World Trade Center as we saw before. And the SMR in each cohort was calculated based on the reference, the national rates, and also there were internal comparison. In this case, a Poisson regression was used because the time was comparable in the two cohorts, compared to comparing World Trade Center and non-World Trade Center firefighters. So the next slide shows, well, these are the characteristics of the population. As you see, the cohort was a little bit more diverse. In the age was similar somehow. It was a bit more diverse in the non-New York City, group, and in terms of smoking, both had a very low rate of smoking, but still a little bit higher in the non-World Trade Center cohort. And the proportion of death was higher here, also in the non-New York cohort. Okay, next slide. So these are the SMR. These are similar to what we saw before. We saw it for the overall cohort. This is the FDNY component of it. The reduction in mortality is even more striking, even more stronger compared to US, compared to the overall cohort. And the other cohort also presented a mortality benefit, except for suicide, and well, except for violence is not significant. But you see the magnitude is lower. There is, in fact, the SMR is closer to 1, so there is less pronounced decrease in mortality. And the next slide shows the comparison, the direct comparison. So comparing, in this case, we really adjusted for age and the other characteristics. So the results in any case are a little bit different, but basically we have about half mortality in the World Trade Center compared to the non-World Trade Center firefighters. And for most of the other causes of death, this is true, except for digestive cancers that are important. So this result, as I said, has been reported earlier this year with Ankura Singh as the first author. The next slide just show basically both firefighter cohort have lower expected mortality, but the one on the World Trade Center exposed was lower. This reduction was stronger compared to the non-World Trade Center, which suggested that there is something beyond the healthy worker effect, because the assumption here is that the healthy worker effect was similar in the two groups, in the two cohorts. And the one aspect that obviously we hypothesize as explanation is this medical monitoring treatment program that has been offered, tailored to the World Trade Center cohort, which may have contributed to this mortality benefit. Next slide. In the second comparison we did was regarding law enforcement officers, policemen basically, which was, as you remember, one of the large categories in the, not in the fire department cohort, but in the other two cohorts. And here we didn't have such a nice comparison cohort as for the firefighters. However, my friend John Vina, when he was at SUNY Buffalo, put together a cohort of policemen from Buffalo, which is now run by John Violanti. John Vina left to become a president of the University of South Carolina, in fact. So we compared the group of 11,000 law enforcement officers from the World Trade Center pooled cohort, basically from the general responder cohort and the DOH, again, age, and then with the same follow-up, with the cohort from Buffalo, which included 1,500. It was smaller. There was an older cohort. We tried to make it as comparable as possible by using the same age criteria, etc. And we just compare the two groups, similar to what we did with the firefighters. This paper has not been published yet. My former postdoc, Mara Khalife, is the first author. The paper is under review. So these are unpublished results. Next slide. So obviously the number of personnel is larger in the World Trade Center cohort. However, the number of deaths is larger in the Buffalo cohort, because although the age range was the same, Buffalo policemen were older on average. We have a slightly better mortality in the World Trade Center compared to Buffalo. And for some of the other causes of death also, there was a favorable mortality in the World Trade Center. However, the difference was not statistically significant at 95% level, except for respiratory diseases, where the reduction was particularly strong and it reached statistically significant. You see that for the other causes of death, even for external causes, was slightly higher in the World Trade Center. So again, here we observe a similar effect compared to what we saw in the firefighters, much less pronounced though, and probably this is due somehow to the fact that we have a smaller cohort to compare with. So the next slide. Okay, I have a few slides on the survival of cancer patients, but I think we can skip this because this is something that presented last year, and also for sake of time, I would skip the next 3 or 4 slides. Can you skip the next one also, and the next one? Okay, and the next. Okay, so we go to the next one, and this should be the, no, sorry, one more. No, sorry, we can go to the previous one, sorry. Okay, so this is my conclusive slide. There is clearly a healthy hiring and healthy worker effect in general in this cohort. However, there is more than that. That's really the bottom line here. And what this more means, probably means a more favorable lifestyle, which is somehow related to this healthy hiring effect. However, we believe, at least I believe, but I think my co-authors also are convinced that there is a very strong, very positive effect of the World Trade Center Health Program in shaping the mortality of this cohort, which in our view justifies, the expansion of this program to all eligible World Trade Center rescue recovery workers. Well, that's basically what we say. And finally, this is a plea mainly to our sponsors, many of whom are here. We think that the latency for many cancers, but also many other causes of death, is not yet fully matured in this cohort, and continuing follow-up of the 3 cohorts and this combined effort would really be very important to have a fully estimate of the magnitude of the effect of these different forces, which are really unique, very important for the World Trade Center workers themselves, but also I think important to understand how this unique type of exposure, including then the subsequent medical experience, impact on mortality of a group of workers. So my next slide is the acknowledgement. As I said, there is a very large number of people involved. I have here, at least I would like to mention the institutions. So New York State Cancer Registry, as I said, they really played a key role in facilitating this collaboration between the different institutions. Maria Shimura, the former director, Icahn and Baozen Chao, my old colleagues and good friends at Mount Sinai, Andy Todd, Chris Desar, and Moshe Shapiro. As I said, the colleagues at Buffalo for the collaboration with the policeman cohorts, the fantastic group at the Department of Hygiene, Health and Mental Hygiene, with Jim Cohn, Mark Farfel, Robert Brackville, and especially Ji Hui Lee, who really led the main paper on this paper, and their collaborators. Dana Ashim Christensen used to work with me at Sinai. Now she went to Norway, but she's been very much involved in the early phase. And the great group at Fire Department and Montefiore and Albert Einstein, with Charlie as a MPI, Rachel, Marilis, and the other people, and Ankura, which unfortunately I forgot to write here, but I mentioned before. And finally, Malak, who was working with me while she was at Stony Brook. And I think that's all. Thank you very much. I was really very, very pleased to present this work, which extended over a number of years. To me, has been an extremely rewarding collaboration work with all these people and also to have the support of the program at NIOSH. Well, thank you very much.
Thank you, Dr. Boffetta. Really appreciate this informative presentation, especially being overseas. And also a thank you to technology and Dr. Hall for being on standby. So thank you very much.